Good afternoon, everyone. My name is Maria Bucur, and I'm pleased to present to you today the progress related to my PhD topic, Diabetes Mellitus across pancreatic diseases. I'm a 40-year resident diabetology doctor, and my vision is to decrease the burden of diabetes mellitus. My mission at the moment is to improve prognosis of pancreatic disease patients by achieving well-controlled diabetes mellitus. In order to achieve my mission, I have two ongoing projects, and I would like to introduce you now into my first one, which is investigating therapeutic options for preventing or delaying diabetes mellitus in prediabetic patients. So prediabetes is the term used to describe a population whose glucose levels are above the normal range that not yet meet the criteria for diabetes. And as you can see, the prevalence is quite high. Moreover, 5 to 10% of this population will become diabetic yearly. Currently, the American Diabetes Association recommends that we implement lifestyle modifications that can reduce the risk of progression to type 2 diabetes up to 70%, or prescribe metformin in case of high-risk population. But in the light of new available medications, such as the GLP-1 receptor agonists, our aim was to identify the most efficient intervention to prevent diabetes mellitus. And we started our research with the following clinical question, and we used the PICO framework. We investigated adults with prediabetes that were given any type of intervention, and our outcomes were the diabetes mellitus incidence and the change in the three glucose indices. We included only randomized controlled trials, and we hypothesized that lifestyle modifications are followed by a great risk reduction than pharmacotherapy. Using the following search key, we searched three major databases, and after the process of selection, we ended up with 324 articles that matched the inclusion criteria. And now I would like to show you our final results. Here you can see our main outcome, the incidence of diabetes. We performed a network meta-analysis, and on the right side of the slide you can see the network graph with the circles representing the interventions and the lines representing the direct comparisons between them. On the left side of the slide you can see the level of evidence for each of the comparisons. As a measure of effect, we used the risk ratio. When compared with control, we can see on the plot that metformin plus intensive lifestyle intervention and GLP-1 receptor agonists reduce the risk of progressing to type 2 diabetes with 73% and 72% respectively. However, we can see that the RRs are almost overlapping, meaning that there is not so much difference between the interventions regarding their efficiency. However, we can see that physical activity is the first intervention that has a high level of evidence, and that is also above the interventions recommended by the ADA, intensive lifestyle intervention, and metformin. We also evaluated the effect of the interventions in reducing the glycemic indices, and here you can see their effect in improving hemoglobin A1C at 1 year. Here, only the two interventions, interventions on the top of the ranking proved to decrease hemoglobin A1C with clinically significant amount. And although curcumin is in the top of the ranking, only one study was included for this analysis. However, we can see again physical activity being on top of intensive lifestyle intervention and metformin. When it comes to improving fasting plasma glucose, the first 5 interventions proved to reduce it by clinically significant amount, and on this plot we can see that sulfonylureas were the first in the ranking. However, again, only one study was included in the analysis, and we can see the same pattern with physical activity being on top of metformin and intensive lifestyle intervention. Lastly, when we talk about improving postprandial glucose, we can see that the first 9 interventions reduce it by a clinically significant amount, with zinc supplementation being on top of the ranking. However, again, only one study including in the analysis. And here we can see that only for physical activity we have a high level of evidence available. A novelty of our study was that we looked at the effect of the interventions on reducing the glycemic indices on multiple time points. And here you can see the effect on 3 months, 6 months, and 1 year. the measure of effect was the change from baseline, and we can see that in case of lifestyle intervention and physical activity, fasting plasma glucose and 2-hour plasma glucose are most reduced at 3 months, with the effect being plateaued or diminished at 6 months and 12 months. However, for metformin treatment, we can see that the effect is more stable in time. So our study has some notable strengths. First, we included only randomized controlled trials, and we evaluated new drugs available, such as the GLP-1 receptor agonists and the SGLT2 inhibitors. And we also evaluated the effect on the glycemic indices stratified by follow-up duration. However, we faced some limitations, being that placebo and control were frequently used as a comparator, and also we faced a high heterogeneity among the studies. Based on our research, we can conclude that metformin plus intensive lifestyle intervention and GLP-1 receptor agonists are the most effective intervention to prevent type 2 diabetes. Secondly, lifestyle interventions yield the greatest glycemic improvement at 3 months with diminishing effects afterwards. However, metformin treatment effect seems to be persistent in time. Based on our research, we can advise clinicians to act early in preventing type 2 diabetes and not necessarily use intensive treatment regimens such as intensive lifestyle or enhanced education, because they don't seem superior to the conventional regimens. But they should use reinforcement strategies to sustain the long-term glycemic control more than the 3 months time point. For researchers, we can ask them to evaluate the sustainability of long-term metformin plus intensive lifestyle intervention and further gather data on the 1-year effect of the GLP-1 receptor agonist, and most importantly, to explore strategies to sustain patient adherence to the lifestyle changes, and importantly to the physical activity that we saw has greater importance. I'm happy to say that we submitted our manuscript yesterday to the Lancet Diabetes and Endocrinology, and we are waiting for their answer. Moving forward, my second topic is investigating the time dependency of beta cell function failure during acute pancreatitis, a registry analysis. In 50% of the cases of acute pancreatitis, patients will develop hyperglycemia, and their blood glucose levels are independently and, most importantly, dose-dependently associated with AP severity and mortality. So managing blood glucose levels it's an important step in the patient care. And there is scarce data on the beta cell function during AP. So our aim is to evaluate beta cell function during AP, and we can do that either directly by measuring insulinemia or C-peptide levels, or indirectly using the total dose of insulin needed in order to maintain normal glycemic levels. We started our clinical research with the following question: what is the time dependency of beta cell during the course of AP? And since we are interested in the endocrine function of the pancreas during AP, we would evaluate adults with acute pancreatitis and examine their glycemia during the course of the disease and gather information about the insulin administration, the total dose, the day, and the route of administration. And we hypothesize that in the early phase of the acute pancreatitis, there is a high insulin necessity, while in the late phase, there is a low insulin necessity. This could help us to provide evidence-based recommendations for insulin treatment in AP. We plan to use the acute pancreatitis registry provided by the pancreatic study group, and currently we have 680 patients that received insulin treatment that we can include in the registry analysis, and we are still gathering data, further data needed for the study. To summarize, my first project is already submitted to the Lancet, and I hope to finalize my second project by the end of this autumn. As additional activities, I participated in the European Pancreatic Club last year, and I will go again this year in Düsseldorf. And I want to thank you for your attention and leave you with the words of William Osler, that medicine is a science of uncertainty and an art of probability. Thank you.
Thank you for the presentation. Who has questions? Yes.
Congratulations on your nice presentation. I was wondering why the physical activity performed even better than metformin and intensive lifestyle changes? What is the pathophysiology behind this?
I actually looked into this for the discussion part of my paper. So insulin resistance is the main driver of this prediabetes and also diabetes disorder. And actually I found that physical activity increases the expression of the glucose transporter 4 on the surface of the cell membrane, which can increase the uptake of glucose from 7 to 20 times. So probably this is the case that physical activity is more efficient than diet, even though of course diet increases the fat disposition around the body, but physical activity helps the muscle to become more insulin sensitive.
And is there any type of physical activity that is better than the others? What did you find something in the articles?
So here we included all types of physical activity, but we did perform a subgroup analysis that I did not show here. So we grouped resistance training and aerobic training, and on that analysis it showed that aerobic training performed better than resistance training.
Thank you.
At least in Germany and some other countries, we have an epidemic of Ozempic, Wegovy, and GLP-1 agonist combined with GIP. I don't know whether that's the case in Romania and Hungary so far, but they are so far more effective than lifestyle changes, which usually peter out after at least 1 year. Is there any evidence you could include from studies with GLP-1 and combinations?
Yeah, unfortunately, I had few studies with GLP-1 receptor agonists, and they only, like the follow-up was only maximum of 1.5 years. So far, that's why I said, like, an implication for research, more research is needed in order to see if they have prolonged results over time. But we saw that lifestyle does not have prolonged results. So probably they can perform better.
Thank you.
Yeah, thank you for your presentation. I have two questions. The first regarding to your first project. So you mentioned in your PICO framework the education levels. Did you see some association with the education levels?
No, what I meant by education was a type of intervention. So yep. Education meaning just giving flyers and informing patients about healthy lifestyle, basically. So it was not related with the level of patient education, if I understand correctly. That was...
Yes, sorry then. And my second question is regarding your second project. It would be a multicentric or a single center analysis?
It's a multicentric because the registry gathers multicentric data.
Thank you.
You're welcome.
The beta cell failure project, how long are you planning to follow patients? What sort of data do you have in the registry?
So the patients were basically follow-up from the admission until discharge, and we have patient forms for each follow-up day where we can see their glucose levels and the treatment administered, including the insulin.
So what time are the follow-up dates after discharge?
No, after discharge there's no.
You're not planning to?
There is no data on the registry, yeah.
Because I think it would be worth also
it would be,
looking at that as well. I mean, we have evidence for that in many sort of situations. Any other questions? Yes.
Thank you for the nice presentation. What do you think if the metformin is combined with physical activity? Can the metformin dose reduced, or it should be also the same, or what is the practice?
Well, I think they have synergic effects. So metformin basically works by reducing the blood glucose levels between the meals. Physical activity basically, as I said, can increase the glucose uptake in the muscle, and the effect can last up to 3 days. So if you performed physical activity today, the effect can last up to 3 days. So probably their effect, I mean, surely it's synergic, but I didn't think about reducing the metformin dosage, but it could be an interesting thing to do.
Any other questions, Mahmoud?
Yes, I have 2 questions. So you mentioned like physical activity. How was physical activity defined in the studies? Is there any common definition of physical activities for these patients?
We included any type of physical activity. So they performed from cycling, swimming, running, strength training, even just north walking. Usually in the studies they performed physical activity for 3 days per week, usually 1 hour per day for 3 days per week, which was quite similar between the studies. So basically this is like the physical activity regimen. Any type of physical activity was included. Probably that's why we have high heterogeneity, but that's why we try to do that subgroup analysis with the aerobic versus resistance.
Was it possible to do this subgroup analysis?
Yes, but only to include a limited amount of studies.
Yeah. All right. And my second question regarding your second studies, do you have data which kind of diabetes these patients have? Type 1 or type 2 diabetes? And are you planning to do separate analysis based on that?
So far, I did not see any type 1 diabetes patient, but if we will find it in the registry, then we can, if we can have more, then we would subgroup them.
So all the insulin was indicated for type 2 diabetes then?
Yes.
Your population. Okay. All right. Thank you.